Welcome back. This is the second case we are going to discuss here in a spotting case series. And under this playlist of a spotting case series, we have recently started. You can see here we have discussed the first case, and this is the link given here that is present in the playlist of spotting series, case series discussion. And here we are going to discuss the second case, the present case. And present case is a very important condition commonly seen in smaller age group, especially children, and sometimes this disease may present as intestinal obstruction. So let's go through it. A 14 years old female presented with abdominal pain off and on and distension of abdomen for the last 4 days. For the last 3 days, she had multiple episodes of vomiting along with fever, recorded as 100.4 Fahrenheit. Patient is also complaining of inability to pass flatus and pieces for the last 60 hours. On further history, patient is giving history suggestive of passing a long white tubular structure, roughly about 12 centimeter in length, in her vomitus, following which the attendant of the patient, they bring her for admission in a tertiary care hospital for further management. As far as education status is concerned, the patient and her family, they are illiterate, and patient is non-smoker, and there is no history suggestive of trauma. So the whole of the family along with the patient, they are illiterate, and patient is non-smoker with no history suggestive of trauma. There is also no history suggestive of any chemical intake or long-term drug intake by the patient for any indication, and there is no history suggestive of instrumentation in the recent past. There is history suggestive of previous hospitalization 2 times in last 1 year for similar complaints, followed by relief after conservative management at local village hospitals. Now here you can see these important negative histories, they are very important. Why patient is presenting with distension of abdomen? We must rule out any chemical intake and any long-term drug intake, especially we must rule out any history suggestive of anti-tubercular drug intake on a chronic basis, or a 14-year-old female child. We must rule out any instrumentation through the genitalia by the attendant or the family members at local level for any criminal abortion. Sometimes it may lead to peritonitis and this picture, distension of abdomen. So all these things we must ask or we must look for, either if the patient can tell us, very good. If not, her mother or father, we can contact and we can draw out these important history findings. As far as the examination findings are concerned, patient was conscious and oriented to time, place, and person. Pulse rate around 118 per minute, left arm supine, hypovolemic, although the blood pressure 96 by 64 millimeter of mercury, right arm supine. Respiratory rate 18 per minute, thoracic predominantly. There's distension of abdomen. Then saturation oxygen, it was 95% on room air. Icterus absent. Clubbing absent. Hand tremors absent, but pallor and pedal edema present. The intraoperative CVP 4 cm of H2O. Lymph node palpable, especially the inguinal and cervical area. Multiple lymph nodes. Then per abdomen findings. The abdomen was distended. Bowel loops, peristalsis can be seen off and on, and it was visible through the abdominal wall. It was giving an impression of some underlying obstruction. Abdomen was tender on palpation, and rebound tenderness was present all over the abdomen. Tympanic and dull note variability was seen all over the abdomen. At some places it was resonant, and at some places it was dull. The bowel sounds were exaggerated. Although per rectal examination findings, they were not adding up, they were not significant in this patient. The spinal and paraspinal region within normal limits, and the features suggestive of ascites on examination, they were present. Our provisional diagnosis was acute on chronic intestinal obstruction due to worm infestation. And why we have made this provisional diagnosis, although we were having various differential diagnoses, like maybe a case of ileal stricture due to abdominal tuberculosis, or maybe a case of some criminal abortion at local village level leading to peritonitis and distension of abdomen. These were our differential diagnosis. But the first differential diagnosis, that is our provisional diagnosis based on history and physical examination findings, we kept it as acute on chronic intestinal obstruction due to worm infestation. And this is because patient is giving history suggestive of previous 2 similar episodes of hospitalization. That's why chronic intestinal obstruction. And it is an acute presentation, acute and chronic, and the previous 2 similar episodes, they were relieved, they were get relieved on conservative management, and patient was also giving history suggestive of passing a white tubular structure through the oral cavity about 12 cm in length, could be possibly Ascariasis. That's why we are keeping it as worm infestation. Let's see what next. Now, as far as the significant investigation, apart from the routine blood investigation, and patient was having eosinophilia, in this patient urine pregnancy test was negative. We ordered for an X-ray chest AP view, X-ray chest anterior-posterior view, and it was suggestive of multiple air fluid levels with a small bowel obstruction features. In emergency, ultrasound abdominal scanning was available, and that was suggestive of ascites. and dilated bowel loops with splenomegaly. And this was the X-ray findings. The air fluid levels, you can see here that there is suggestive intestinal obstruction. The air fluid, and there is a level 1, 2, multiple, and this was suggestive of intestinal obstruction. Then what we did is supportive management. As a part of it, we inserted a Riles tube number 14 for gastric decompression, and Foley's catheterization was done with number 14. Intravenous broad spectrum antibiotics started, as we were not knowing it could be a case of something else other than worm infestation may be possible. So that's why a broad spectrum, even antibacterial, we have covered. Then packed red blood cells and FFP were arranged with cross matching of blood, and she was having B positive blood group. Our plan was to just go for laparotomy under general anesthesia with endotracheal intubation. And what was the intraoperative findings? Now this is the important question, must be in our mind. After going through the various history and physical examination findings, making our provisional diagnosis as acute and chronic intestinal obstruction with worm infestation, and our plan to go for laparotomy under general anesthesia with endotracheal intubation. Now intraoperative findings that was revealing like this. You can see here, the intraoperatively we found that the small bowel was distended, almost completely blocked, with tubular structures. The impression of tubular structures, if you can appreciate here, a whitish something is shining from inside, tubular structures almost completely obstructing the jejunum and below the ileal part also. And this here is the mesentery. You can see the mesenteric vessels pattern, right? Now the question for all of you is just identify this part of small bowel based on the pattern of vessels in the mesentery. That's why I've kept this picture here, and just write down in the comment box, identify this part of small bowel based on the vascular pattern shown in the mesentery, right? Now this was what we have extracted from the lumen. Can you see here? Around 1.4 kg. This is just a part of the whole thing what we have extracted. The rest of the thing were kept in the bucket that was present inside the operating theatre. Around around 1.4 kg ascaris were removed after doing enterotomy followed by repair with suture silk 30 round body. This is a typical appearance of ascaris worm, right? They are also known as round worms. Now in post-operative care, we transfused 2 units of red blood cells, packed red blood cells. Patient underwent chest physiotherapy in the post-operative period. On 6th day onward, we started with anthelmintics when we allowed the patient orally on 4th post-operative day, right? I'm sorry, just wait. Then in antihelminthic group, we prescribed her tablet albendazole 400 milligram once a day for 5 days, and that is to be taken again a single dose after 2 weeks. Then appropriate antibiotics coverage will be broad spectrum consisting of a cephalosporin along with metronidazole as intraotomy was done, and with gentamicin. For 5 days we have given to this child. Along with that, analgesics and other supportive care was given, and low molecular weight heparin 0.4 ml subcutaneous OD for 5 days. These were the important supportive treatment that was given to the patient in the post-operative period. And finally, this was the intraoperative picture. This was what we have extracted out from the lumen, and this is the take-home message. And what is that? That ascariasis can present as anemia with intestinal obstruction, especially in children, and for that, regular deworming with social awareness regarding this disease can prevent this deadly presentation. Like you have just gone through, you have just watched the presentation of intestinal obstruction, may be dangerous to life for any patient. So this is a take-home message. Regular deworming in the especially the smaller age group, and you must be knowing how this ascariasis is caused, and this is caused by a roundworm, especially Ascaris lumbricoides, or this spread through the ingestion of the infected vegetables or fruit infected with the egg of this worm. And if usually the child age group is affected, why? Because they're usually in the habit of putting the things in the mouth or just playing in the soil, and if that soil is infected with the eggs of this worm, the child any child can easily get infected with this ascariasis, and then again this egg will hatch in the intestine. The larva will go through the hematogenous or lymphatic route through the lung towards the lung of the patient, and after, let's say, 1 week, that larva will again go up through the airway aerodigestive tract, and it will be again re-swallowed, and then that larva will develop into an adult worm in the intestine of the patient, like adult worm you have just seen, like this. These are adult worms, and they will again excrete, they will shed their eggs in the stool, and that will get mixed with the soil or the vegetables or the fruits. And so this is very important to just clean the fruits and vegetables whatever we are bringing at our home. And anyway, if it is infected, it is a good idea to take tablet albendazole 400 milligram once a day at, let's say, regular 3-month or 6-month interval wherever there is this disease is endemic, right? So this is a take-home message, and thank you for watching this spotting case series. Thank you.